دكتور نادية تدخل شكرا. السلام عليكم.
السلام ورحمة الله وبركاته.
So shall we start? Yeah. Assalamu alaikum wa rahmatullahi wa barakatuh. Jum'ah Mubarakah. First, I would like to thank all our participants for joining us today. It's our pleasure that they are joining first, and would like to thank all our speakers, Dr. Nadia Al-Hazmi, Prof. Tariq Uwaida, Dr. Abdul Rahim Gari. Thanks to Top House Conference for arranging such webinar for them, and I'd like to thank sponsors. Really, the company, they are doing a great job for their initiating such topic, which about navigating the challenge of severe postpartum hemorrhage with a prominent speakers. Thanks to Norfa Desk for their high cooperation for arranging such webinar. On the same time, I would like to tell everybody that this webinar is with 4CME from Saudi Medical Specialization. It's 4CME for all OB-GYN and for pharmacists also. On the same time, would like to announce for the 5th OB-GYN conference, which is going to be in Crown Plaza Hotel, Riyadh, Digital City. It's going to be in 24-25 November. So everybody welcome to join us there. On the same time, we have 5 international speakers and many national speakers with live surgery. It's Crown Plaza Hotel in Riyadh, Digital City. Before it's in 23, we are going to have hysteroscopy workshop with 8 CME hours going to be there with Prof. Osama Shawgi and 3 national speakers. So welcome everybody to join us there. It's our pleasure that you will be with us there. We are going to talk today mitigating the challenge of severe postpartum hemorrhage. I see until now more than 500 participants joining us, though that today we have in Saudi Arabia more than 3 webinar and workshop is going on. So everybody is joining us, which is a great thing for Dr. Nadia. She will talk about postpartum hemorrhage practice. Dr. Nadia, she's a consultant of obstetrician and gynecology, fetal-maternal medicine, East Jeddah Hospital. She's a member of the Saudi Scientific Council. Dr. Nadia, I know her for a long time. She is one of the best consultants. We studied together in the same diploma from Ministry of Health in Riyadh, but she is younger than me, definitely. So I'd like to thank Dr. Nadia to join us, and she is well-known figures in Jeddah. Welcome, Dr. Nadia. You can start.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Doctor, for your nice introduction. نقول بسم الله الرحمن الرحيم والصلاة والسلام على رسول الله. Without any delay, we will start our lecture, which gonna be about. It will be introductory about the postpartum hemorrhage, and we are going to focus in the severe postpartum hemorrhage. Just give me a second. My apology.
Take your time.
Okay. Can you see my lecture now?
Yeah, it's clear.
Okay. Bismillah ar-Rahman ar-Rahim. So why today we are speaking about severe postpartum hemorrhage, and we are going to speak about the challenges and opportunity with my other presenter, because of the complexity of the cases and our failure to recognize severe postpartum hemorrhage in the right time. There is a multiple definition of postpartum hemorrhage, starting from 1,000, whether it's post-vaginal delivery or cesarean section, and the severe one where we are talking about amount which is more than 2,000 men. Whether this or that, as long as there is changes in the hemodynamic stability of the patient, we are going to consider it as severe. Secondary postpartum hemorrhage is considered as abnormal excessive bleeding from the birth canal between 24 hours and 12 weeks postnatally. And last Monday, we had a lady who presented with severe secondary postpartum hemorrhage, where we need to do hysterectomy for her, and that's why re-emphasize that you should think about the secondary postpartum hemorrhage whenever you have a lady presented post-delivery. There is different guidelines have been developed globally because of the complexity of the condition, and it's common, and it's one of the major killing cause of ladies. This is again the other society where different guidelines have been published. Regarding the maternal mortality in Saudi Arabia, we have done a great job from reducing the mortality from 24 per 10,000 to 17. And since 2016 till now, we were unable to achieve a great statistical difference. The published number is 16, 17, but we did not improve because of the large number of cesarean section and morbidly adherent placenta, and still it's one of the killing cause in Saudi Arabia. So if we are going to talk about severe postpartum hemorrhage, we are talking about 2 liters of bleeding, and a lady with alteration of the hemostatic stability, where the blood pressure have been affected or the pulse have been affected and blood pressure has been affected. We should always think about the golden hour, because we can save ladies and we can prevent further going for surgical intervention and loss of an organ. So the first hour is really, really important, and we need to do aggressive rapid intervention, where we need to prevent acidosis, coagulopathy, and hypothermia. I mean. So these 3 triad, if we can break it, we can save those ladies. And it's unfortunately a lethal triad, where whenever we have coagulopathy, we will have increased lactic acid in the blood. The acidosis will affect the hypothermia and coagulopathy as well. So this triad should be broken in the golden hour. And once we establish that this lady has severe postpartum hemorrhage. So unless we break it, we cannot get and utilize an excellent results by the end of the day. We want to reemphasize that it's a teamwork. It's not one-man show. Whenever we want to save lives, we need to have a team, and that team should include a leadership and a proper communication and a method to monitor our intervention and those patients, and we should have mutual support from the other department as well. If we are going to talk about the 6th step in managing postpartum hemorrhage, whether it's mild or severe, we are talking about 5 major steps in managing those ladies. And it's not one after another. All these 5 steps should run together hand in hand to reach a good results. The first thing is the identification of the severity of the hemorrhage, and this is one of the major, has major impact in the right intervention. Then the communication and involvement of multidisciplinary care from the early hours, resuscitation, monitoring and investigation in the major postpartum hemorrhage, and how we can arrest the bleeding, starting from prevention, which is the most important step, and going to the treatment in the cases where we have severe postpartum hemorrhage. Identification of the bleeding. Every clinician should be aware how to estimate the blood loss. We have multiple methods, and when we were juniors until now, we were looking to these pictures where we can have a rough estimate of the bleeding, and you can see from the beginning the 30 mils, and here the last picture is 1,500, and usually this is a very fast way of recognizing the bleeding. But mind you, that usually with the visual estimation, we have underestimation, and you can see in this picture how the rough visual estimation is wrong. So just have in your mind that whenever I have visual estimation, that I need another method to calculate the actual blood loss. You can see that we collect all the blood by these bags, and make sure that with this method, usually we overestimate because it might be diluted with the liquor. So an overestimate and underestimate, so we need to have a number in between. There is another method of doing it, and I believe, especially in the operation room, they are adopting this way, where we are measuring the net weight of the sponges, and each cream at 1 gram, it's 1 millimeter of blood. Again, if there is polyhydramnios or just make sure that we are calculating the actual blood and have rough estimate of the bleeding, so we can announce that we have severe postpartum hemorrhage, and we can diagnose in the right time and intervene in the right time. Mind you, the shock index is very, 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 very easy tool and should be utilized in each maternity care, where are calculating the maternal heart rate divided by the systolic blood pressure. And if you have a figure of 0.9, this is mean that we should start the massive transfusion at this time. And this is mean that the lady have lost a great part of her blood volume. because of the physiological changes during pregnancy, we adopted the 0.9 rather than 0.5 or 0.7 in the non-pregnant ladies. Another way which helped our resident and our registrar in the maternity suite, that the rule of 30. So if the lady have a decrease in the hematocrit of 30%, or of the hemoglobin 30%, or fall in the systolic blood pressure of 30%, and raise of pulse by 30%, this is mean that this lady have hypovolemia, and definitely the shock index is high, and we need to initiate massive blood transfusion. This is different classes of how we are defining the postpartum hemorrhage from class 1 to class 4. And you can see that the amount of loss is one of the indicator, then the percentage of volume, the pulse, blood pressure, respiratory rate, urine output, and mental status. And you can see from slight anxious to confused lethargic whenever we have ladies in class 4. So the main aim of this presentation is to diagnose them early when they are class 1 and prevent a reach of class 4 if we can, and continuous evaluation, which class, whenever I call the other department. So I will label the patient that she's having severe postpartum hemorrhage, class 1 or class 2, class 3, class 4, when I speak to the blood bank as well, to know the seriousness of this condition. Okay, when we talk about the communication and multidisciplinary care, we need an army to save those ladies. We need to have all the relevant staff with appropriate level of experience, and whenever we have postpartum hemorrhage, and we need the midwife, we need because they are the first liner, to know how to diagnose, when to call, and what to do in the initial steps. And we need a multidisciplinary care of blood bank. We need to inform the anesthesia and to be alerted, and especially if we have ongoing bleeding and they are having clinical shock. And we don't forget, of course, our expert, our senior expert. Of course, we should start by prevention, as we have mentioned before. The new guidelines that we need to do for all ladies third stage management, active management, not only the high-risk patient. And we should start in major for the minor PPH, aiming to prevent escalation for severe or major postpartum hemorrhage. So the classical teaching that we need to have a large bore 2 intravenous cannula, we need to group and screen, we need to have full blood count, coagulation screen including fibrinogen, pulse, respiratory rate, and blood pressure every 15 minutes. So whenever we have postpartum hemorrhage, even the mild one. And we should add that we should reassess the breathing and airway if the bleeding is still continuous, or if we started with major postpartum hemorrhage, we need to evaluate the circulation as well. The position of the lady is flat. All these steps should be done with the minor PPH, but when we come and reevaluate those patients, we make sure that all these steps have been taken on. We need to keep the woman warm as well, and this is one of the things we tend to forget during while the patient in the delivery suite. And we should transfuse blood as soon as possible if clinically required. We need to have the blood available, infuse 3.5 liters of warm clear fluid. And again, we stress in warm, initially 2 liters of warm azotonic crystalloid, then fluid resuscitation while we are waiting for the blood. And we are going to speak about what urotonic we are going to use with this fluid resuscitation. I just want to stress, I don't think anybody is using starch anymore, but it have been mentioned that it should never be used. There are no firm criteria to start when to start blood transfusion, and the decision to provide blood transfusion is based upon the clinical situation. So a lady who started with hemoglobin of 8 or 9 is completely different from a lady who started the labor with hemoglobin of 4. The degree of loss as well is one of the indicators when to start the blood transfusion. And again, use the shock index so you know exactly that those ladies we need to call for the blood and to start when to initiate the massive transfusion protocol as well. Major obstetrical hemorrhage protocol must be well written and well adopted by every hospital, and they should have internal policy and procedure for such hospital whom they are going to take care of those ladies. And usually whenever you initiate the massive transfusion, they will start by giving the O negative till they get the other unit, and each hospital have the different protocol. Intraoperative cell salvage should be present in the hospital where you can use the blood and while you are preparing more units for those ladies. The first resuscitation, hemostatic resuscitation, usually we give RBCs and platelets and fresh frozen plasma 1-1-1. There is a different round 1 and 2 and 3 and 4, where the first round the blood bank should release 6 units of each and 10 units of cryoprecipitate in the first round and the second round. And the third round, tranexamic acid, where we give 1 gram intravenous over 10 minutes. And tranexamic acid should be given within the first 3 hours. If you are going to give it after the first 3 hours, usually the benefit of tranexamic acid is not as good as we aim. So we diagnose the lady with severe postpartum hemorrhage. We start after doing all the prophylaxis not to have the severe postpartum hemorrhage, and the golden rule is the oxytocin. We resuscitate, we call, we prepare the fluid, we doing the thorough resuscitation to make sure that they are not in coagulation. So this circle, and I'm going to speak about it in the coming 30 seconds or so, it should be continuous till the patient is stabilized. So we mentioned that she has already IV lines. She's already cross-matched, and by the time she's the hemodynamic is stable, we should start the blood transfusion. We should all the time do the screening for coagulation and see whether she needs fibrinogen or she needs other factors. And I'm going to leave it for the next speaker. We should all the time resuscitate and see the other organ. The urine output is one of the vital signs in those ladies who are having blood loss more than 1,000. We should measure the temperature as well every 15 minutes. And this is one of the things which are usually not monitored in the suite. They will measure it 1 hourly, but once you diagnose with severe postpartum hemorrhage, it should be measured every 15 minutes. The pulse and blood pressure, we should keep those ladies in continuous monitor to see how they are responding, and God forbidden if they are deteriorated or not. And again, we need to think that with the follow-up of the maternal early warning sign, or if they are getting worse, we should have our chart and see where we are going in our resuscitation. And by the time, if she's not improving, we should think about, do we need to escalate? Do we need to go for the further intervention? The best way of preventing the bleeding is prevention, and usually prevention, as we have mentioned, for all ladies who are in labor, by oxytocin, either 5 units or 10 units with the delivery of the anterior shoulder or after delivery of the baby. Both timing are good. It's a little bit statistically better when you give it with the delivery of the anterior shoulder. And as we have mentioned, the gold standard is oxytocin. Then we are talking about the other prevention. Usually, we tend to use it as treatment if the lady start to have postpartum hemorrhage, whether it's minor or severe. And we can use carbotocin, misoprostol, ergometrin with methergine, oxytocin, and ergometrin as prophylaxis, and ergometrin alone as another urotonic as treatment whenever we have the severe postpartum hemorrhage. And according to the protocol of the delivery suite, carbotocin a little bit is better in having a tetanic contraction if the treatment is available in delivery suite and the operation room, and it's one of the magic drug where we can have achieve good contractions, but never all the other lines are as good as the oxytocin and carbotocin. But when the uterus failed to respond to one line, so you think about the second line. So you are attacking the postpartum hemorrhage from different kind with different kind of treatment and with different action as well. The procoagulant, I'm not going to speak in details because it's going to be the presentation of my colleagues, but usually, as I have mentioned, the tranexamic acid 1 to 2 gram should be given in the first 3 hours of the events. Then the fibrinogen, and we need them to treat the coagulopathy. And we are going to speak about the recombinant factor and where to place it in the severe postpartum hemorrhage with the evidence that's going to be presented in the next presentation. We have mentioned the importance of tranexamic acid, and there is plenty of evidence behind it. There is more than one study have been done. The largest was the postpartum hemorrhage women study, where they did they test the tranexamic acid when it's giving in the golden 3 hours, and they noticed that the need of surgical intervention have been reduced dramatically. Okay, so we have a lady where we tried to prevent the postpartum hemorrhage by giving the prophylactic treatment. She did not respond. And mind you, it's not only the high risker, even the low risk patient, they might just start to bleed. And for a reason or another, sometimes we cannot figure out what is the predisposing factor for the severe bleeding. So she has a severe bleeding. We try to treat her with all urotonics. It did not work, so we'll think about balloon tamponade. The balloon tamponade give you time for the senior to come sometime, and it's one of the treatments. Sometimes or many times the lady will respond to the balloon tamponade. Mind you, with doing all this intervention, you have to do a continuous monitoring of your intervention. So you don't delay the surgery, you don't delay the escalation of the next step, aiming to, yes, conserve her uterus, but her life is more important. So this balance should be done all the time, and following up her vital signs should be the golden rule. So we have, if the lady is not shocked and she is hemodynamically stable, so we think about embolization if we have that service in the hospital. And I believe now most of the hospital, they have these services. If she's not stable, so the embolization is taken away. Regarding the tamponade will help us in two conditions. If I'm going to transfer a lady from the territory, from villages or an area away from the main city, we can do either the external non-pneumonic anti-shock garment, where you can see in this picture, you can just wrap it around the lady and you can send her, and this will reduce the bleeding till she reach a safe area or a hospital where they can give further services. And we can, the balloon catheter as well. And this is one of the way to control the bleeding, especially in ladies whom they have the uterus is failed to contract.
2 minutes left, Dr. Nadia.
تفضل.
2 minutes left.
Yeah, I will wrap it. So the balloon would reduce the 86% of the bleeding, and you can see the percentage of those ladies who are responding to the balloon as well. The most important thing you can see the escalation. So we support with the treatment, coagulopathy, balloon, and laparotomy embolization, and last resort hysterectomy, and it's going to be presented by my next speaker. In the last 2 minutes, I want to speak about maternity safety bundle, and it have been adopted by the North American and European as well, where the 4R are really important: the readiness, recognition, response, and recording, to audit ourselves and improve ourselves. So each unit should have their hemorrhage cart, where all the supply and treatment are there, including the uterine tamponade and immediate access to hemorrhage medication kits as well. And the testing ourselves regarding the response team according to the policy, the availability of the senior consultant, and the massive transfusion protocol as well. With the protocol, we need to do the drilling to know whether we are ready whenever we have these emergencies. We should recognize the cases, as we have mentioned, how we can recognize the bleeding, and what are the measures to do the proper intervention and the proper timing. And once we finish, we sit together and sit with the family as well whenever we have significant bleeding, so they will know what happened to their loved one, and we should know what are the checklists to be for the emergency management, and auditing ourselves that there is an area of improvement or area of weakness where we need to audit ourselves. Then, as I have mentioned, the reporting, we presenting them in the morbidity meeting. That have been adopted by the ACOG, I believe, almost 4 or 5 years ago, and they noticed that the mortality and morbidity have been lessened, and the transfusion have been lessened as well. In Wales, they adopted a system which is almost similar in the severe postpartum hemorrhage, and they noticed that the outcome were really good because everybody speaking the same language. They have systematic way of looking after those patients. This is just a whole sum of the whole presentation, and it's going to be fragmented. I mentioned the first part, then the second and third part going to be presented by by other speakers. And I want to conclude my presentation with this quote from the WHO director: "For each mother who dies, there is a family that suffer, community that become weaker, and a country that gets poorer." Thank you very much for your listening.
Thank you very much, Dr. Nadia, for your interesting lecture. There is a high cooperation between Saudi Women's Society and Society of Hematology. So I'd like to thank Prof. Tariq Uwaida. He's sharing with us this talk about webinar, and this shows the importance of the role of hematologist in the management of postpartum hemorrhage. Prof. Tariq Uwaida, he's a professor of hematology at Al Faisal University and consultant of hematology and transfusion medicine at the Department of Pathology and Laboratory at King Faisal Specialist Hospital and Research Center, Riyadh, Saudi Arabia. If anybody have questions and answer, please put it in questions and answer. All our speakers are going to answer your questions, Dr. Nadia, Dr. Prof. Tariq, and Dr. Abdurrahim Gari. And we'll keep answering the questions. We'll keep questions and answer at the end. So welcome, Prof. Tariq. Please start.
Assalamu alaikum. Thank you, Dr. Samir. It's just let me, yeah. Assalamu alaikum jami'an. It's my pleasure to talk to usual customers, our colleagues from obstetric and gynecology, which I've been luckily dealing with them for many years, and we had shared knowledge and experience. Today, I have been asked to talk about the role of hematologist in management of postpartum hemorrhage. We had listened to a very nice talk by Dr. Nadia, who elaborated about the magnitude of the problem. And I hope we can work together to minimize the loss we still encounter in the country. 16 or 17 is not acceptable, and I hope we can come to a day that we have a single digit of women loss due to maternal or delivery problems. During this lecture, I will go through some introduction, just highlight few of the points which already been highlighted by Dr. Nadia. I'll talk about what hematologist needs from obstetrician before what obstetrician needs from hematologist. And then I'll take you through steps in the diagnosis of bleeding tendency, which is the problem that bother us a lot. And whenever the patient with the bleeding disorders plan for pregnancy and delivery, we have a lot of problems that encountered during the whole course of this journey. Then finally, I'll highlight a few points in the or steps in the management of postpartum hemorrhage, again from the hematologist point of view. Clearly, we had listened to a nice intervention by Dr. Nadia. So we all know that worldwide, 800 women die every day from preventable cause related to pregnancy or delivery. That's not acceptable in these days. I think we still have a room to improve it. We still have a room to work together to minimize this event. And around 73,000 women die every day from directly childbirth-related postpartum hemorrhage, which may complicate up to 13% of deliveries. It's nicely being mentioned by Dr. Nadia. What is the postpartum hemorrhage, how we define the primary and secondary. However, what I would like to clarify and stress on is the management of postpartum hemorrhage requires identifying the underlying cause, allowing an individualized approach. As has been mentioned, the guidelines gives a broad pathway for all practicing physicians, nurses, and other how to deal with this, but still there are a big room for individualizing approach, particularly if we know what this lady come from, what is the background of her, and namely here I'm talking about particularly patients with hematological diseases or patient on anticoagulation. Definitely the multidisciplinary team of medical obstetrics and hematological intervention would be the ideal way of handling these patients. So what is needed from obstetrician? As hematologist, what we need from you guys before we get interfered and which will help us to interfere early is to early identification of the risk factors for postpartum hemorrhage, and that can be from obstetric point of view, but particularly from bleeding point of view. We all know that in the country we have a relatively high prevalence of bleeding disorders compared to other countries. The coagulation factor deficiencies being reported in the country much more than the being reported in other places. To give you one example, which is the Glanzmann's thrombocythemia, which is one of the rare platelet disorder, happens 1 in 1 million in West and East. In Saudi Arabia, we have 1 in 200,000, so that we have 5 times more chances to have Glanzmann's, and this is applied to all the bleeding disorders. So the high prevalence of bleeding disorders makes the chance to have a bleeder woman is much higher. So that can be identified from the history before or during the antenatal, and that will help a lot on planning and avoiding the complication that may happen postpartum. Early identification of predictor of possible cause that may worsening the hemorrhage, and that can include also part of the history identification of patients who are on anticoagulation. Again, we have big a portion of the patients who are on anticoagulation due to thrombophilia or due to recurrent abortion or due to pregnancy-associated thrombosis. So all these are population that need to be identified early and plan their delivery. The effects of different intervention can be also planned early, particularly during the antenatal, if we know what's the status of the placenta. If there is a chance this patient can be a preputial placenta or placenta accreta or whatever, that would increase the chance. And the same, what is the mood of delivery that you would expect? Is it a normal, or you are planning for a cesarean section? Once we know that, I think now we can step in as hematology and start to evaluate the case by case from all aspects. Identify the cause, the possible cause for bleeding, and if we get involved early, we can diagnose the problem, because many of the patients or many of the people around, they may be a carrier of a bleeding disorder or on an anticoagulant or on antiplatelets, which been there for some time, and unless we get the early call, the early diagnosis, it will be difficult to do that during delivery. And based on that, we will start suggesting the management strategy, and then we suggest the post-discharge again a plan. To do that, I think the first is, as I mentioned, early diagnosis. Identify during the first antenatal, and that's a message to all our colleagues in obstetric. Please include a history of bleeding in the early of the prenatal or during the early phases of pregnancy about the bleeding. That can be done either by a simple cause of bleeding, and once you have a suspicion of a bleeding, please refer the patient directly to hematology. So start to do the bleeding assessment tool and pictorial chart and identify the cause of bleeding. Anemia is important, and I'll focus a little bit about anemia and what is the role of anemia in hemostasis. Workup of a bleeding disorder is not easy, and unfortunately, if we get called to do a bleeding diagnosis during delivery or just before delivery, most of the time we will not be able to do that, because this is an extensive workup of doing 13 factors and platelet estimation, platelet functional tests, and that's all complicated tests that needs more time. Drug history, and particularly the anticoagulation and antiplatelets, need to be identified early, and that will help us again for planning the management before, during, and after delivery. Once we have a bleeding patient, we have an extensive history of bleeding, which will help us to identify what could be the possible. Is it a primary hemostasis or secondary hemostasis? And as you can see, we don't expect you to do all that, but we will do it once we have the patient referred to hematology. We expect our colleagues in hematology to dig in most of these questions and perform the bleeding assessment tool to identify high-risk patients, where can be added by the pictorial blood assessment, which again helps us to know if the patient has more chance to bleed during delivery. Have said that, I think when we have a clear reason to suspect a bleeding disorders, we need to start early doing the CBC, blood film, routine coagulation, fibrinogen, platelet function test, because we have time to do that before patient going to delivery. To confirm the diagnosis, as I mentioned, the screening will just give us a hint that this patient may have a bleeding tendency, but there are many specialized tests. I will not mention them here, but the message that I would like to send to you, that most of these, if not all of them, require 1 to 2, sometimes 3 weeks to be done to get the results from the lab. Move to the more important point, which again needs to be identified early. ideally during the early pregnancy to see if the patient has anemia. Anemia is a bit common, and in one of our surveys across the country, we had identified anemia in almost 11% of the females in the country. So 1 in 10 you will have anemia, and 1 in 30 you will have iron deficiency, which makes her more prone to anemia during the pregnancy, this is a preventable cause. And anemia is not only to maintain her delivery of oxygen, but when we talk about hemostasis, anemia is very crucial part to maintain the hemostasis. Anemic patients will be more bleeding, have more bleeding tendency. And if the patient has a bleeding disorder, that makes her, she's more prone to have anemia during pregnancy. So I would recommend that we should look at the hemoglobin upfront and look at the ferritin. And if the ferritin is suboptimal, I would advise to start giving IV iron upfront in the pregnancy, and even in the late phases of pregnancy, because that would require at least 1 week to raise the hemoglobin by 1 gram, so avoid any transfusion. Now, what is the management strategy of anemia? Again, that depends on the stage of pregnancy. If it's early, you can try the oral. If the patient cannot tolerate oral, go directly to the IV iron. But definitely when it comes to the end stages of the iron, of the pregnancy, iron can be treated with IV better than giving any oral, because we need the lady to go to the labor with her best level of hemoglobin, so that will help her to pass the delivery, and at the same time prevent or reduce the postpartum hemorrhage. A transfusion, I'm a transfusionist, but usually I'm against transfusion, because that's something we keep only in situation like what Dr. Nadia showed us. When you have massive blood loss, you cannot do anything other than massive blood transfusion. But if we can avoid transfusion of all products upfront by making the patient in optimal position to go through the delivery without any bleeding, that would be ideal. There are many complications of transfusion. I will not go through it, but we try to avoid transfusion unless really we need the transfusion. When it comes to what is the optimal red cell transfusion, it's not known, but we know that if there is danger from inadequate or excessive transfusion. If you have a patient who have a hemoglobin less than 80, this patient needs to have transfusion. If the patient receive excessive transfusion, and that's what happened with the massive transfusion, that caused the DIC virtuous cycle of blood dilution, coagulation dilution, and then you would continue to have bleeding and continue to put blood supply. There are many markers again being shown, the blood volume loss, how much blood volume lost and how much need to be replaced, what type of replacement. I saw the protocol for replacement of 1 to 1 to 1, and that's what's ideal, because giving only backed red blood cells or giving only fresh frozen plasma, that would imbalance the hemostasis and would cause more bleeding. Massive transfusion protocol should be established in any hospital, for not only for postpartum, for any massive transfusion, and the blood bank need to be alerted upfront about the tendency of that lady to bleed. So they prepare the protocol, be it 6 units or 4 units in different rounds, but that will make the blood bank alert. You don't need to tell the blood bank when the patient is already started to bleed, because that's a bit too late for preparing the units and help you to make the optimal transfusion of the patients. Cell salvage had been mentioned by Dr. Nadia, and I'm happy that it's available in obstetric hematology, in obstetric hemorrhage in some centers. We use it in mostly in the cardiac cardiac and liver transplant, but there are centers which use these salvage, which help you to reduce anemia and use of allogenic blood. So it's recirculating the blood lost during the delivery. A recent survey showed a volume of recovery ranging from 380 to 900 can be recovered from during the delivery and can be reinfused. But keep in mind that the field for delivery in obstetric is a bit different from that in cardiac or in liver transplant, because you have amniotic fluid and mucum, which can cause contamination. You have hemolysis, maternal infection because of the maternal passage of the blood, DIC, which again can interfere with the blood that is being done by consumption of the blood product. So you are infusing not only a blood, but also fibrinogen degraded products. And finally, red cell alloimmunization, which may cause by reinfusing of some of the fetal. So it's a bit of unwelcome, but it's one of the procedures that can help you, especially if you get in a situation where there is no available blood. Coagulopathy, Dr. Nadia had put it in picture, and I think coagulopathy is one of the major problems in obstetric hemorrhage. It may occur in 25% of the causes. There are many factors that is behind this coagulopathy. The consumption of coagulation factor is one of the major component that induce coagulopathy. Again, you infuse a big volume of fluid replacement, which cause dilutional effect. There is an endothelial activation from hypothermia and acidosis, and both of them are thrombogenic by itself, but at the same time, it may induce coagulopathy. Ongoing bleeding exacerbates all types of coagulopathy that would result in more and more bleeding. Part of the coagulopathy happen as the end products of the fibrinolytic system, which get initiated by hyperfibrinolysis and produce fibrinogen degradation products, which is an anticoagulant that interfere with the platelet activation and fibrin creation and cause more bleeding. Now, what could be a solution? I think we have a good experience with some point of care tests, because we know that the conventional tests like PT, BTT, INR lost their value in acute BPH because of the time. It may take up to minimum 1 hour to get the results, which is you don't have the pleasure of that. Adding to that, there are during pregnancy, some of the hypercoagulable state by having high level of factor 7 and factor 8, but all these can cause shortening of the BT and BTT, and it will not give you a real picture of what's going on in the coagulopathy. ROTEM or a TIG system had been introduced in many surgeries, and part of these areas where it gets introduced is the obstetric areas and gynecology, where you can have a global evaluation of the coagulation defects that may happen during the process of delivery. And adding to that, it would help you to direct the replacement fluid, depends on the changes that may happen, where you can look at different areas of the graph and see if that is due to activity of coagulation factor, where you need to replace it with FFB, or there is a fibrinogen defect, so you need to boost it with fibrinogen concentrate, which is preferable more than the cryoprecipitate, or if there is a problem with the platelet, and you can infuse platelet or tranexamic acid. So all these can help you, but it may need to have all together to come up with a treatment protocol. I looked at the protocol presented by Dr. Nadia, and I think it's good. The only thing you need to see how you can minimize the massive transfusion, because as we minimize the unneeded transfusion, I know the situation with massive bleeding requires replacement, but we keep in mind that this replacement put us in a virtuous cycle. And if we can minimize the need to what is really missing, I think we will break this cycle and improve the quick stop of the bleeding. Tranexamic acid is a good tool, and it should be incorporated in the protocol, and the result had showed better response for using 1 gram and repeated even the dose with the less tendency to have thrombosis. Recombinant factor 7 is another tool. And recently, almost 1 year ago, the EMA had approved it and included as one of the labels for the treatment of severe BPH, and that happened after the multi-center study, which looked at the value of the use of a single dose of 60 microgram per kg in patients who have a severe postpartum hemorrhage, and they found that there are fewer women underwent an invasive procedure to stop the bleeding, which made that a tool. However, I should warn you, because this is again a thrombogenic. The situation of delivery and the pregnancy is thrombogenic, so adding another thrombogenic need to be evaluated. So it's a good tool, but we need not to overuse it and to look for thrombosis. Anticoagulation is another area which may complicate the scenario, and we need be carefully to know if the patient is on prophylactic or on therapeutic, and use the guidelines of stopping the anticoagulation enough time, at least 12 hours, if not 24 hours before delivery. And if the patient situation is quite thrombogenic, maybe we can change the patient to unfractionated heparin, which will give us a 4 hours stop before the procedure. Patient involvement is quite important, and what I usually do if we got a pregnant lady who get to us early, I involve her in the decision making by keeping her a record of the bleeding and putting her on some of the replacement, particularly for those with rare bleeding or coagulation factor during the pregnancy, and tell her to involve the obstetrician, especially if she has floating obstetrician, where she moves from one area to area seeking for a different obstetrician opinion, to involve her that there is a risk during bleeding, so she needs to be planned and prepared. This is a nice algorithm which been bought in blood, which will show the different resources, different protocols that can be used for stopping the postpartum hemorrhage, and the importance of utilizing all the resources to get as quick as possible to stop the bleeding. So in conclusion, I would send few messages. The first message to all our colleagues in obstetric field: no women should enter the intrapartum period already anemic, and local process should be in place to avoid such occurrence. Early identification of anemia and correction is essential. Early detection result in a better intervention and less complication, and early involvement of hematologists give more time to diagnose and plan the management. At the end, it's a multidisciplinary work, and I would really encourage the Obstetric Society to work with us to come up with a system like having the ROTAM or any system that would avoid losing a woman. And as Dr. Nadia ended her talk, losing a woman is losing a society. And by that, I would like to stop here and thank you.
Thank you very much, Prof. Tariq, for your interesting lecture, and to end the lecture with the same which Dr. Nadia also tell us. I would like to mention that this webinar is running through the Twitter. It's running also through the YouTube. So anybody like to follow, they can keep follow up through the YouTube and through also webinar and through Twitter. We are running into action. You see, Dr. Nadia, she talked. Now Dr. Tariq, a hematologist, now will go into action. I would like to thank Dr. Abdurrahim. He's outside Saudi Arabia, but he's keen to give us the lecture. So I'd like to thank him, Dr. Abdurrahim Dari. He is Associated Professor for Department of Obstetric and Gynecology at Al Qura University, Mecca, Saudi Arabia. He's a consultant obstetrician and gynecology oncologist at Al Murjan Hospital, Jeddah. He's also my neighbor. So I'd like to thank Dr. Abdurrahim to join us. We want to hear action from surgical management of catastrophic postpartum hemorrhage. Welcome, Dr. Gary.
Assalamu alaikum, Jami'an. Good afternoon, everybody. First of all, thank you, Dr. Samir and the panel. I'm going to just run through a few points in the surgical management of postpartum hemorrhage. So basically, I'm going to talk about, let's say, if all the measures failed, like to control the postpartum hemorrhage, what should we do now? We are like at the operating theater, but I'm going to mention a few practical points and like maneuvers and techniques, what to do. And then I'm going to present something like a modified packing techniques. Hopefully that will be very helpful. And then we'll give just a brief case if we have time for that. So I think most of the points were mentioned by Dr. Nadia and by Dr. Tariq regarding what to do and the approach. But in general, always remember time is like a very important factor, not to delay the steps. So if you have one step failed, remember just to proceed before it's too late. Always call for help. Always remember that, like if you have a fresh brain, even if you have like a colleague and he's there around, always call, always contact, or call. We always say load the boat, where you can involve hematologist, other anesthetist, you can involve the vascular surgeon, the surgeon, anybody there. They can always help if you need it, and don't like lead your ego to cause more harm than good. As mentioned by Dr. Nadia, you can utilize all the uterotonics, and always, as I said, remember to act with active management for the next step before it's too late. So always communicate well with your anesthetist, with frequent blood tests, etc. Don't assume the anesthetist knows everything, because we have like always like inshallah good anesthetist, but you cannot guarantee that. So always communicate with the anesthetist and about the the status of the patient, vital signs, etc. As Dr. Tariq said, cell saver, honestly, I think it's a life-saving machine or facility. We have it in the operating room. There is some debate about amniotic fluid. But in general, if you weigh the risk and benefit, I think cell saver is very useful. We always use it after the closure of the uterus. So hopefully at that point, the field is clear, so we can utilize it to save lots of blood, and we'll retransfuse to the patient again. So this is just a brief slide about the electrolyte imbalance, etc. But the one-to-one, this is utilized from the literature by the trauma literature, but I think this is very applicable in obstetrical bleed and gynecological bleed. If you have a massive transfusion, I think that will be the best to consider. And I know even some anesthetists, they don't believe on that, but I think we have to apply it, make sure that you have it ready. Cryo, again, is important, but most of the time, we need FFPs to give volume. But if you think you overloaded the patient with cryo, FFPs, you may use cryo to give you more concentrated factors. Activated factor 7, as Dr. Tariq said, you don't have to overuse it, but again, it's one of the important medications you have to consider in the bleeding. So we'll move to the maneuvers. We know that everybody knows the B-Lynch maneuver. B-Lynch maneuver is one of the best maneuvers. You can do it in the operating room. You can just use a zero vicryl. And the idea of using the maneuver as if you have somebody who's compressing the uterus itself. To make it easy, I always straighten the needle. So you can do it manually as if you are sewing at home. So make it straight. It will be easier to pass the needle according to the diagram here. It's just like putting braces. If you remember the braces when we wear a suit. So this is the best way of doing it. But I do use a modified B-lunge, which is easier. So I do the same entry from here, but you can do it as vertical line here. So passing anteriorly and then posteriorly, then coming back and tie. And then we do 1 and 2, especially if you have a placenta previa sometimes with a bleeding bed. You can apply it, but always remember, you can apply 2 or 3 sutures, but vertical, and never put it horizontal because it will obstruct the outlet. So putting few stitches with a 0 vicryl will be superior, but again, you can do also a B-lunge. This is one of the maneuvers you can do it, which keeps like compression on the uterus itself. Using balloons, Dr. Nadia mentioned all the balloons, and sometimes you don't work in a fancy hospital and you have to use whatever you have. I think you can use Bakri balloons if you have it, and if you don't have a Bakri balloons, you can do like SB tube, which looks like 2 tubes putting in. This is quite fancy. What I use in cases where you are stuck in the bleeder, just bring a Foley's catheter. You can use a 24 gauge or even 18 or whatever you have there. You don't expect to fill it as much as you can, but believe it, it can take up to 60 or 80 or 100 cc's of normal saline in the balloon. So you can just inflate it inside the uterus for tamponading. And I would always wrap it with the Kerlix. If you have a Kerlix or any sponge in the operating theater, you can wrap it. And I think that will maximize the effect of tamponading. But in the same hand, don't forget to bring it down from the vagina. So you put it both together and then you can deflate it after 24 to 48 hours. And it really works. So if you have a Bakri balloon, that's well and good. You can inflate up to 400 or 500. But if you don't, always remember, Foley's catheter with a bigger, larger gauge or balloon, it will be very useful. Embolization is one of the best methods to control intrapartum bleed or postpartum bleed. However, this is if you have a planned patient with Akrita or whatever, and you're expecting bleeding, you can just speak to the intervention radiologist. They can place the balloons. The balloons are excellent where you can keep it in a sheet. You inflate the balloons after having the baby out, and usually, if this is the external iliac, that will be, the internal iliac, I mean, they can place the balloon here. So once you have the baby out, you can inflate the balloon. You can control your bleeding, do whatever you want, but don't forget to deflate the balloon while the abdomen is open to make sure that the bleeding or the hemostasis is well controlled. So don't deflate the balloon after the closure of the abdomen. Always remember to deflate the balloon. And keep the sheets for 24 to 48 hours, meaning if there's any bleed, it will be very easy for the intervention radiologist to embolize. They can use the PEETs or any embolizing agent while the sheets are there. So number one, as rules, don't remove the sheets, and always remember you have to keep the sheets for 24 hours to make sure there is no bleeding. And always remember to deflate the balloon while you are interoperative, while you are seeing the field. So if there is any bleed, it will not be misleading, because if you have an inflated balloons in the OR and then you deflate it post-op after the closure of the abdomen, the patient may start oozing again. Always communicate well with the team, experience the way to handle the balloons, how to inflate or deflate yourself, your assistant, and the nursing team. Remember to educate the nurses not to stop the irrigation for the sheets, because it may cause a major thrombus in the arterial site. So everybody should know how to handle the sheets. Uterine artery ligation is another way of controlling the bleeding. Always remember, when you control the bleeding by using the uterine artery ligation, you have to do it bilateral, never do it unilateral. Unless you have an extension, you want to control only one side. What I do usually, I try to open a window in the broad ligament that makes it very specific to the uterine arteries, and that will minimize the risk of what you call it urinary kinking or injury, because sometimes I've seen people, they just take a wide or big bite throughout the broad ligament. That may cause kinking to the ureter. So if you can do this opening in the broad ligament, you can pass your needle into the medial to the uterine arteries. That will be the best, very specific to the uterine artery and avoiding ureteric injury and at least ureteric kinking. Vascular ligature of internal iliac. Again, you may have to have a vascular surgeon or gynecologist with you, or if you are trained, you can do it. It's not very difficult, but again, I think anybody can do it, honestly, by doing the anatomy of the retroperitoneum where you can have the external iliac, the internal iliac, and usually the ligature will be here before the posterior trunk. So this is the left side of the pelvis. This is external iliac artery. This is internal iliac artery. And here you can see what we have. The ligature is already placed. And I'll show you a video. Hopefully the video will work. But this is, again, bilateral, and it decreases the pulse pressure. And it's very helpful. You have oozing in the pelvis, even by doing a hysterectomy or before doing the hysterectomy. And it really helps in cases where you have a major postpartum hemorrhage. So basically, before you start the internal iliac ligation, you have to do the phantom application of the sutures. I always put it as doubled with the right angle. And this is basically to show the, I try to put on the video. So this is how we do it. We make it as double and always show the nurses how to hold it. But then once you start doing, this is the video of internal iliac ligation. So this is external iliac artery. We're trying to expose the artery as an external, and then so we're trying to expose the internal iliac artery. This is the internal iliac artery. Now we can see it. The most important part, when you pass the clamp, we pass it lateral to medial to avoid injuring the artery, the vein. So it's lateral to medial. We were trying to pass beyond the internal iliac artery, and now this is beyond. So we pass the double ligature, zero vital. And then we tie. So basically, if you have a good exposure, that makes your life really easy. You have a good assistant with you. Shouldn't take more than 5 minutes on each side to ligate the internal iliac artery. And then this is another case. This is quite bloody case where we have a major blocking and the patient was very woozy. So it's not always bloody like this case. This is a bit bloody. So again, we try to expose the external iliac and then the internal iliac artery. And as I said, it's very crucial, very important to move it from lateral to medial to avoid injuring the external iliac vein. So we can see this is external iliac and this is internal iliac artery. So this is internal iliac. We're passing the ligature just below the internal iliac artery. and then we tie it. Just for the sake of time, we're going to move to the other slide. So never hesitate if all the measures failed to pack the abdomen. As I said before, it's too late. Once the patient starts medical bleeding, DIC, she will bleed from everywhere. So if you think you're not going to control the bleeding, you tried even after hysterectomy, sometimes you may have to pack the abdomen. This is the way where I do it. And alhamdulillah, never failed where I pack the abdomen for 24 hours or 48 hours, and then I remove the packing in the ICU. Even you don't have to take the patient back. We use 3 Kerlix roll and always keep it dry, and we connect the Kerlix roll together. So it will make it like a long, what they call it, like a piece, like long piece of packing to put it inside. And then what we do, we try to close the abdominal wall. After packing inside, you put an area where it's open, and then we use a PDS here in the lower part, upper part. This is a midline incision, assume. So it will be packing with the zigzag form. So you put the pack in the base of the pelvis, and then you pass it this way, like a zigzag form, to avoid overlapping and affecting the drain. And it should be very tight. And you pack the abdomen as if you're packing the abdomen with the trauma or with the surgeon. But the trick here, if you put a stitch, like sutures to, like a stay stitches to suture the fascia, and then stay stitches to suture the subcutaneous fat and the skin, but you don't tie it. You just put the stitches above and below, and you keep it like untied. And I'm going to show you what I mean. And then you put a stoma. So you bring your drain, your pack, you bring it from the stoma. So that will be as a drain, but at the same time, next day you remove the pack, or the day after, it depends how easy the patient. Always remember, you have to put what you call it, the patient on IV antibiotics. After 48 hours, you come to the ICU. You can give the patient some sedation with propofol, midazolam, and then you can remove it. And hopefully that will be very helpful. So as I said before, this is how you're gonna have the midline incision. So we put the sutures there as stay stitches, but you don't tie it. You suture the fascia, you suture the subcutaneous fat, but you don't tie, and you keep it all together there. So this is 3 stitches for the fascia. So you keep it this way, you don't tie. So we have 3 stitches for the fascia, 3 stitches for the fat, and 3 stitches for the skin. You keep it all together. This is our careless pack. It's coming outside from the abdomen. Already we sutured the above, the upper and the lower part of the incision. I'm keeping only 5 to 6 centimeters here to have my pack out removed next day. And then this is exactly what you're going to see. This area is sutured by a PDS. This area is sutured by a PDS. And then we put the staples here. You put the staples here. But this is the middle part of the abdominal incision. It's opened, and you have the stay stitches already there. And then this is how we remove it. After 48 hours in the ICU, you give some sedation to the patient, midazolam, or there will be like an anesthetist or the intensivist. He can help you. And then under aseptic technique, this is how we have the stoma there. We have a drain. So all the sutures are inside here. So next day, as I said, we do a CBC, make sure the patient is completely stable, aseptic technique, and then you give the patient IV sedation. And this is how we remove it. You open the colostomy bag, and you open the colostomy bag, and you just pull it slowly. So you have all the sutures ready to tie. So I'm just preparing all the sutures, arrange it. We have the Vicryl for the fascia. We have the Vicryl Rapid for the subcutaneous fat. So now I'm gonna just cut the suture where I fixed the pack, and I'll start pulling after giving the patient some sedation. So we make sure that we count the calyx, make sure that it is 3 because we did put 3. And after that, once it's out, I'm gonna tie all the sutures and we just remove the colostomy bag. So as I said before, once you remove the the pack, you're gonna just tie the vicryl of the fascia, and then you tie the vicryl of the subcutaneous fat, and then you just close the skin. We do a CPC, we do routine post-op care, and there is a small risk of wound gapping, but this is only skin, nothing major. And that will really save the patient. This is just a step where, as we know that the most stressful part for the surgeon and for the patient is to take the patient back to the operating room after 2 days or 1 day to remove the packing. This is a very useful way, and inshallah, it will not fail. Risk of bleeding after removing the pack is very low. This is just a brief case, just to summarize. As I said before, always evaluate, proper timing, proper consultation, always call for help, communicate well with the anesthesia, blood bank, with the hematologist. Remember how to give the best and the maximum doses of uterotonics. So try to utilize everything. As I said, active management before it's too late. Always evaluate and communicate with the anesthetist about the findings and what to give, especially the rules of 1-to-1-to-1 when we have a massive transfusion in the operating room or even in the floor. But in general, as I said before, try to utilize whatever you can. Always remember to use the cell saver if you have it available. And thank you very much.
Thank you very much, Dr. Abdurrahim, for your interesting lecture and for the action and the video. There are some questions which is in question and answer. I'll start with Dr. Nadia. What is the role of NOFA7 in the management step of severe postpartum hemorrhage, and how you can actually position it in grantee for higher efficiency?
Okay, NOVA7 have been studied thoroughly in cases of severe postpartum hemorrhage, and it have been proposed by the European Society to use it whenever we have severe postpartum hemorrhage. If we are talking about a bleeding where the bleeding is more than 2 liters, and if the fibrinogen more than 2 grams, there is a role of the factor 7, and it should be utilized in the right timing. Most of the obstetrician use the NOVA7 a bit late when the lady have utilized most of the coagulation factor, so it doesn't work in this condition. So if we are we have severe postpartum hemorrhage and we use it with the tranexamic acid, the primary results of these studies and it have been adopted as policy, it has a role. And they found that most of the intervention surgeries have been reduced at least by 70%, if my memory is helping me. So it has a role in the severe postpartum hemorrhage. And in these cases, we need to ask our colleague from the hematology to aid us where to place it and what the right time to use it. But in the time being, if we use tranexamic acid and still we have ongoing bleeding, so this is the right time to use the NOVA7.
Thank you. What is the ideal dose?
Can you help me, Dr. Tariq?
Definitely.
My mind is occupied with my daughter. She's a bit sick.
Yeah.
Oh, sorry for that. Yeah.
It's okay.
The only thing I would like, just before the dose, to add to Dr. Nadia, the optimal time of use is crucial for the work. If you use it too late, it has no value. If you use it when the patient has low platelet, acidosis, hypothermia, and no enough fibrinogen, it will not work.
Yeah,
and the optimal dose is between 40 to 60. The study showed that 60 microgram per kg single dose had better than the 40, and that the recommendation from EMA.
Thank you. You know, all the participants, they are saying that very nice lecture and very excellent information and very good video films in the comment they are sending to us through WhatsApp and through the webinar. A questions to Dr. Prof. Tariq, what is the time interval of the round of giving the blood product, backed RBC, platelet, and etc.?
This is back to the management process during the postpartum hemorrhage. So as mentioned by Dr. Nadia, the first round you need to give one of these the units, the 3 types of units, and then you evaluate the response of the patient. If still the bleeding ongoing, and still there is changes in the hemodynamic status, you go for the second round. And how many rounds you need to go, that's of doubt. Here's the time where you may need, after the second round, you may need to consider the hemostatic agents, which will help you. And if you are lucky to have the system of Rotem around you, that will help you in this time where it will guide you to which type of products you may need to interfere, rather than giving round and round. And especially we know that once we start these rounds, it may end by having very massive transfusion of replacing the whole blood of the volume of the patient without achieving the hemostasis.
Thank you. How often how many minutes the interval do you need to check for clotting profile in cases of massive blood transfusion protocol?
I wouldn't advise for clotting. Yeah, for clotting profile, I wouldn't advise because it loses its value. The only test that will be helpful is the Rotem, because that's a dynamic. It's a point of care. It's near you. In 20 minutes, you can get the results if you have it. But while if you would like to use the BT and BTT, which is a laboratory-based test, it will be of useless. It will come to you after you finish the whole journey. So you continue doing the management according to the bleeding, but that's a clinical decision at the time of stopping the bleeding. But you cannot base on any laboratory test to do this procedure.
Usually in emergency, we depend upon the clinical judgment rather than doing the test, because we are in acute situation where the patient is losing her blood. We call either the oncologist or vascular. So we are, especially when we are using the second round or third round. So we are depending on whether the patient is clotting or not, and if there is ongoing bleeding or not, and the replacement of patient rather than going and doing it. Usually we do it once the patient stabilized to see is she in need of further specific coagulation factor or not. But during the emergency and hustle, usually we don't do that test. We go for clinical evaluation during the emergencies.
Thank you, Dr. Nadia. Questions to Dr. Abdurrahim Gari. You have many successful stories for severe postpartum hemorrhage. Can you tell us one of the most successful story? Because if you want to write a book, you write huge book in severe postpartum hemorrhage, and how many times we keep calling you. Tell us the most successful story which you want to mention it in severe postpartum hemorrhage.
Thank you very much. Tell a story which happened in one of the private hospital. I was coming from Mecca, and then I just passed by IMC to see one of my patients, and then I thought maybe I'll go to the washroom in the operating room, and then the head of anesthesia, he told me, "You are here." There was a patient who's completely unbooked. I think she was coming from Mecca to Jeddah with the bleeding, and then they took her inside the operating room, and they found it was an accreta, previous cesarean sections, completely unbooked. The patient was really very, very sick and major bleed. I went inside the room. There were like maybe 3 anesthetists, and there was a vascular surgeon, urologist, like everybody was there, and they were not be able to see even the field. And one of the anesthetists told the other one, just go out and talk to the family, telling them that she's not doing fine because they cannot control whatever. The point is, I used to work with somebody like my senior, the fellow, the consultant. He used to say, if you have a bleed, save the patient life, ligate whatever you can ligate, and then worry about the ureter and others. I always remember that. So at that point, they were trying to find where is the ureter, urologist, and then the vascular saying, okay, we need to open the retroperitoneal space. And this is what I told him: just clamp whatever you can clamp, save the patient life, and then we can always like fix and repair everything as long as the patient is fine. But wasting time, I think this is where we always miss that point. We waste time looking for ureter, looking for whatever. I know in retrospect, it's easy to criticize that, but when you are there, like in the hot seat, you can't like, think sometimes. That's why you need somebody who comes to you with a fresh mind just to help you, whether a colleague from any like service or whatever, but they can always help. So anyway, we went in, alhamdulillah, it was fine. We did like bilateral internal iliac ligation, and then the ureter was fine. Nothing was ligated, but they were like insisting, urology were insisting, the ureter is there. The obstetrician said, I'm not sure. So everything went well. Alhamdulillah, she was fine. She was in the ICU for a few days, but I did the packing for that lady because she was almost in a DIC. We did the like cesarean hysterectomy. She was very sick. She was oozing everywhere. So I told them, we're going to pack and close the patient. We'll correct the medical DIC, medical bleed. And alhamdulillah, she was fine after that. So the message is ligate, clamp, try to save the patient's life, and then worry about the others. Don't ignore the ureter and other structures. But as long as you can just clamp and save the patient's life, control the bleeding first, and then you can find out what happened after.
So always pass by washroom, please.
Yeah, they always remember this story in
yeah. At the end, I would like to give each speaker 1 minute to give us 1 or 2 sentences about severe postpartum hemorrhage and his message. We start with Dr. Nadia.
Just be ready all the time. Think about the risk factor of having postpartum hemorrhage. And it's ideal to start antenatally to optimize your patient, as Dr. Tariq mentioned. Avoid anemia and rank your patient whether they are high risk or low risk patient for postpartum hemorrhage. Be ready, be ready, be ready. And remember the 4R whenever we have severe postpartum hemorrhage and adopt it in your hospital.
Thank you. Prof. Tariq.
Thank you, Dr. Samir. I think I just echo Dr. Nadia tamaman. I think early detection, early planning, early intervention is the key. And again, I'm calling the Society of Obstetric, please work together. Let's find a way, if we would like to minimize the postpartum, if the 17 or 16 still is the highest due to the postpartum hemorrhage, and if we can do something to minimize this to single figure, I think we should all work together to make that happening.
Thank you. Dr. Abdurrahim.
Okay, so my point is always expect the unexpected. I know most of the PPH happens and unplanned, unexpected. But if you expect there will be some bleeding, even accretas or let's say a previa or whatever, be over prepared. And if nothing happens, that's well and good, but don't underestimate the case, because if you think there is a previous surgeries, adhesions, whatever, be over prepared and always call for help. I think sometimes we don't want to call for any reason, but always call for help. And I always say load the boat, so involve everybody. And as I said, maybe a simple suggestion by one of your colleagues may change a lot. Thank you.
Thank you very much. At the end, I would like to thank everybody who joined us. It seems the number is keeping on. Nobody get out from our participant, because it's very interesting lecture, and even through YouTube and through Twitter. So I'd like to thank all participants. I would like to thank all our speakers. I would like to thank Stop House Conference, sponsor company, Norfa Desk, for their actually cooperation. And we need to cooperate more and more with Hematology Society. The Society for Saudi Women Society is open for registration. I want to remind everybody, welcome to the 5th Obigani in Crown Plaza Hotel and hysteroscopy workshop. So please join us. It's in 24-25 November, and the hysteroscopy is in 23 November in Al Habib Al Suwaidi. There will be live surgery from Dubai. Sorry? Live surgery is going to be from Dubai. So thank you very much, and see you again and again in another webinar.
يديك العافية دكتور. شكرا لكم.
شكرا جزيلا. Enjoy your time in outside Saudi Arabia, Dr. Abdurrahim.
Thank you very
And my
much.
best wishes for your daughter, دكتورة نادية.
أشكرك إن شاء الله بسيطة. شكرا لكم.
إن شاء الله. شكرا يا بروف.
مع السلامة. شكرا، مع السلامة.
مع السلامة.